Special thanks to Binay and the foundation once again this year for inviting me to this conference. It's a true pleasure to be here and a great opportunity to give you a quick update, mostly on developments from this last ASCO where there was quite a bit of new information. So what I'd like to do is walk you through the topic of synthetic lethal PARP inhibition and then proceed to checkpoint inhibition, not to be left out from our colleagues from melanoma and non-small cell lung cancer. Then a brief update on the abemaciclib data that George Sledge presented at ASCO. And then finally some comments on HER2 targeting approaches, including the adjuvant affinity and ExteNET data, also combined receptor blockade approaches, and then finally a comment about rare but perhaps important HER2 kinase domain mutations analogous to EGFR mutations in non-small cell lung cancer, including the emergence of second site mutations now that's been noted by a collaboration of ours and by the group at Vanderbilt. So this is the PARP story. The main thing here is to note that Alan Ashworth's siRNA synthetic lethal screen was published in the EMBO journal back in 2008. That's how long it's been. And yet we just now, for the first time, have randomized data in human BRCA mutant breast cancer. Breast cancer was ultimately superseded by the ovarian cancer data, winning approval, obviously, for this class of agents. And it's interesting to note why this happened. Initially, this field was launched by the data on aniparib, including exciting randomized phase 2 data, which was significantly positive, but then it failed to be confirmed in a pivotal phase 3 trial. And around that same time, Jim Dorshow from the NCI had a poster at AACR one year that was very heavily traveled because in that poster he showed binding of all of the half dozen or so PARP inhibitors in preclinical and clinical development, and their binding to recombinant human PARP1 and PARP2. And aniparib did not bind to either one of them. So in retrospect, it turns out that aniparib indeed was not a PARP inhibitor, which accounts for the negative phase 3 trial, but that did set the timelines back for many of the investigations in breast cancer in particular, while they were allowed to move forward in other disease states. So you'll recall that the synthetic lethal approach is actually fairly simple to understand. It's analogous to the two-hit hypothesis of Knudsen, but instead of mitogenic activities with two hits, it's cell death. So this is a screen in BRCA mutant cancer cell lines where they silenced PARP1, and in that context, those cell lines died. And so they reasoned that if they had a pharmacologic approach to inhibit PARP, then they could inhibit repair of single-strand DNA breaks eventually, which then become double-stranded DNA breaks that BRCA normally can handle by homologous recombination repair pathways. But if that's attenuated due to mutation of BRCA, inactivating mutations in particular, then you have a synthetic lethal approach. And this is what accounts for efficacy in BRCA mutant cancers. So at ASCO, the randomized phase 3 OlympiAD study of laparib was the only breast cancer plenary session presentation. This was in 302 subjects. These patients were HER2 negative metastatic cases, steroid receptor positive or negative, deleterious or suspected deleterious germline BRCA mutation, prior anthracycline and taxane, less than or equal to 2 prior chemotherapy lines in the metastatic setting. If they were hormone receptor positive, they had to have had at least 1 prior endocrine therapy. And if prior platinum use, they could not have progressed while on platinum, and it should have been greater than a year since prior neo or adjuvant platinum treatment if they received it in an early disease setting. The randomization was 2-to-1 to olaparib. And the control arm was interesting since no one could really agree on what the most appropriate chemotherapy control arm should be. It became a treatment of physician's choice control arm shown in orange. So the physicians and their patients were allowed to choose between capecitabine, eribulin, or vinorelbine. The primary endpoint was progression-free survival per RECIST criteria. Note the abbreviation BICR. I'm going to call that one out since you may not see that one a lot. That is Blinded Independent Central Review. And that's all the CT images for staging were done by a blinded response evaluation committee. In terms of patient characteristics, this is the young age cohort because of the prevalence of BRCA mutations in young patients with breast cancer because of the familial inheritance pattern, obviously. A very small number of male subjects were also included. The majority of the patients were Caucasian. In terms of BRCA mutations, the simple majority were BRCA1. In terms of steroid receptor status, about half were ER positive, the other half ER negative. Prior chemotherapy for metastatic disease in 71% of the patients, and prior platinums in almost 30%. The treatment of physician's choice assignment, the physicians chose capecitabine 45% of the time for these patients in the control arm, 37% of the time eribulin, and 18% vinorelbine. This is the primary endpoint based on the blinded committee response evaluation. The median progression-free survival in the control arm was 4.2 months with chemo du jour control versus olaparib at 7 months for a hazard ratio of 0.58 and 3 zeros after the decimal for the p-value. The Kaplan-Meier plot is shown on the left-hand side for progression-free survival, showing superiority of olaparib over these chemotherapeutic agents as controls. On the right-hand side of the slide, you can see that there was also a response rate, CRs of about 60% for the olaparib arm, PRs about 9%, and about half that rate for CRs in the chemotherapy control arms. Now, this being only a 300-patient study, it is not powered to detect OS differences, even if one should exist. Consequently, at the bottom of the slide, you can see I typed in the text of the median OS point estimates being about 19 months in both arms, with a non-significant p-value that you might expect for a small-size study such as this one. Now, interestingly, one of the planned subset analysis was PFS, the primary endpoint, based on prior platinum treatment. And on the left-hand side, you can see that in the subjects that did have prior platinums, and recall this is in any setting, some of them had metastatic platinum, some neo, or some adjuvant, you can see that though the hazard ratio point estimate is still around 0.6, the confidence limits cross unity boundary in the 95% confidence interval. So this is not significant in subset analysis, though it's underpowered. You can see based on the Kaplan-Meier analysis at the median, the curves are actually overlapping. So not very impressive activity in prior platinum-treated subjects in this subset analysis. By contrast, in the platinum-naive subset, you can see clear separation of the PFS curves, hazard ratio 0.6, and the 95% confidence limit does not cross 1.0. Next, the adverse event profile. Please don't forget that PARP inhibition does have myelosuppressive properties. You can see that there was a considerable amount of grade 3 or greater anemia in this population, some neutropenia, whereas neutropenia dominated the chemo-treated patients shown in orange. And in terms of global quality of life outcomes, you can see that the results favored olaparib comfortably compared to cytotoxic chemotherapy, as you might expect, in terms of time to deterioration of global quality of life measures. And the quality of life differences were highly significant. So the author's conclusions from the plenary session, and these are taken verbatim, olaparib tablet monotherapy provided a statistically significant and clinically meaningful PFS benefit versus standard of care chemotherapy for patients with HER2-negative metastatic breast cancer and a germline BRCA mutation. Olaparib was generally well tolerated with less than 5% discontinuing treatment for toxicity and a lower rate of grade 3 or greater adverse events compared to chemo. OlympiAD is the first phase 3 study in metastatic breast cancer patients demonstrating a benefit for a PARP inhibitor over an active comparator. My main comment when I saw this presentation, both before ASCO in a private forum and at the time of the plenary, is, shouldn't the control arm for this study have been a platinum salt? And that's for you to decide, especially in a platinum-naive patient. That might be a difficult decision to make because carboplatin as a single agent based on the TNT data has remarkable activity in BRCA gene mutant first-line metastatic breast cancer with upwards of a 70% response rate and very manageable toxicity with carboplatin as a single agent with an AUC of 6, though it is IV, so it is less convenient, arguably. But it's probably also cheaper than a PARP inhibitor. So time will tell where this agent will be integrated with platinums in BRCA mutant breast cancers. Next, as I mentioned, not to be left out, we wanted to look at activity of checkpoint inhibition in human breast cancer. In particular, there was strong rationale for this because it's been known for many years that infiltrates of white blood cells in breast tumor specimens are pretty common. Not only that, they are associated with favorable prognosis even in the absence of any other treatment. So it is a positive prognostic factor in multiple studies dating back probably to the 1970s and then rediscovered in the 2000s. So the rationale was perhaps these white blood cells include T cells, and perhaps you could exploit their presence in the tumor microenvironment by checkpoint inhibition with a PD-L1 or PD-1 antibody. And there were phase 1 studies with expansion cohorts, small studies, however, since they were phase 1, for both PD-1 antibody and a PD-L1 antibody in human metastatic triple-negative breast cancer. And these were typically heavily pretreated phase 1 populations. And in those 2 small studies from different sponsors, the response rates were 18 and 19%. So for a small study with a point estimate on the response rate in the teens, that was felt to be very encouraging. And that led to this much larger 170-patient phase 2 study called Keynote, which happened to be pembrolizumab as the agent to be used. The patients were centrally confirmed triple-negative breast cancers with greater than or equal to 1 prior systemic treatment for metastatic disease and documented disease progression thereafter. Tumor biopsies were obtained in order to confirm the triple-negative status and to measure PD-L1 expression in situ in the tumor specimens. No radiographic evidence of CNS metastasis was allowed in the eligibility criteria, and the patients had to have measurable disease in order to track RECIST criteria. This group was treated with pembrolizumab at 200 milligrams IV every 3 weeks. So here is the best overall response highlighted in yellow, and the best overall response rate in the total population was just 4.7%. So this makes the point when you have these small point estimates from expansion groups in phase 1 studies, the 95% confidence limits on those estimates of 18 or 19% were very, very wide because of the small numbers of patients. Perhaps only in the teens were the number of patients in those expansion cohorts. And so you really do need a much larger population to get really more of the true response rate with tighter confidence bounds. Here you can see ranging from about 2% to 9% in the intent to treat population. There was a pre-planned comparison of the PD-L1 positive versus negative groups. Those are shown at the top in yellow on the middle and right. Again, about 4.8% and 4.7% respectively, so not that much different than the total population. Now, shown graphically in cohort A is a group of previously treated patients irrespective of PD-L1 expression, and shown as the clinical benefit rate, which is not only the 4.5% or so who responded, but also adding in the stable disease for at least 24 weeks, which is about 6 months. That's felt to be a clinically meaningful endpoint in triple-negative metastatic breast cancer in particular. And you can see that that does increase the interest, perhaps, of this class of agents in this disease with close to double-digit responses, particularly in the PD-L1 positive subset, less so in the PD-L1 negative subset. In cohort B, there was a group that was previously untreated and PD-L1 positive, and that group did have a remarkable response rate by comparison, which is 23.1%. Still modest by comparison to other disease states, obviously, but suggestive that there may be an efficacy signal there worth trying to sort out, particularly if there were a marker someday that could sort these out prospectively. These are the Kaplan-Meier estimates for the PFS endpoint, showing the total population, the PD-L1 positive and PD-L1 negative subsets. Clearly, they're all completely overlapping. So there was no evidence in the group as a whole that expression of the ligand changed outcome for the PFS endpoint. In terms of adverse events, exposure was only in about 3 cycles on average for these patients. The median was 3 cycles. So short exposure was typical because of the rapid progression in this patient population, unfortunately. Grade 3 or 4 toxicity that was deemed treatment related in about 12%. Immune-mediated any grade toxicity in close to 20%, as you might expect. And the most common adverse events were those that had been typically shown with pembrolizumab historically, in other data sets from other malignancies. So fatigue, and then all of the inflammatory adverse events representing autoimmune phenomenon that you're very familiar with. So no new safety signals from this cohort of breast cancer patients. So that was the updated ASCO for metastatic disease. Meanwhile, there was quite a bit more enthusiasm for a neoadjuvant checkpoint inhibitor trial that was done by the group at UCSF in the I-SPY2 trial. And you'll recall that I-SPY2 takes breast cancers in the neoadjuvant setting and then exposes them to a novel test agent in a Bayesian statistical model. And based on the observed pathologic complete responses after treatment with the novel agent, they can estimate the probability of a follow-on phase 3 randomized trial in the neoadjuvant setting and the probability that the phase 3 would be positive. And if you have a very high probability of having a follow-on randomized trial that's statistically significant, then you quote-unquote graduate from the I-SPY2 trial. So oftentimes you'll see press releases from this group that indicate that certain new molecules have graduated from I-SPY. That just means that they met this threshold in Bayesian statistics for prediction of future success in a randomized fashion. But at any rate, in these Pembro-treated patients, you can see all the HER2 negatives on the left, triple negatives in the middle, and the hormone receptor positives at the bottom. And if you look at the controls, the estimated PCR rate was only about 13 to 20% for the controls, but with the Pembro-treated patients, it was about 0.3 to 0.6, depending on subtype of breast cancer. And so the differences between around 0.2 and about 0.6 is about triple in all three of these settings, for the HER2 negative, the triple negatives, and the hormone receptor positives, virtually triple the probability of achieving pathologic complete response rates when Pembro was added to the backbone chemo regimen in the I-SPY2 cohorts. And there you can see the probability of a follow-on study being positive is 88% at minimum and over 99% in some of the subsets. So this is now graduated, and there will be follow-on studies in the neoadjuvant setting as a result. Here's a phase 3 trial that's going to be done with pembrolizumab, 2-to-1 randomization, triple negative, T2 or N positive, 855 patients. Chemo backbone is paclitaxel carboplatin, followed by anthracycline cyclophosphamide, and then surgery, and then follow on adjuvant pembrolizumab or placebo. And Pembro is in one arm and placebo in the other. So this will be very interesting to see whether the I-SPY2 graduate will succeed in a pivotal phase 3 trial or not. Here's a similar study also with Pembro. These are patients who have residual disease following induction neoadjuvant chemotherapy with at least 1 centimeter residual or a positive node, and then they'll be randomized to observation or pembrolizumab every 3 weeks for a year. So another twist on outcomes, in this case, post-neoadjuvant. Next, quick discussion about updates at ASCO on CDK4 and 6 inhibitors. This made the oral platform presentation session presented by my boss, George Sledge at Stanford. These were 669 patients randomized in a 2-to-1 fashion to a combination of fulvestrant with or without abemaciclib, which is in the same class as ribociclib and palbociclib. This is placebo-controlled. These are hormone receptor positive patients, HER2 negative, pre or postmenopausal, endocrine resistant, defined as relapse on neoadjuvant or on within 1 year of adjuvant endocrine therapy or progression after first-line endocrine therapy for metastatic disease. No prior chemo for metastatic disease was allowed, and no more than 1 prior endocrine therapy for metastatic disease was allowed. The primary endpoint was investigator-assessed progression-free survival. This had a 90% power to detect a true hazard of about 0.7. 142 centers in 19 countries, so a very large effort, big numbers of patients. In terms of the type of endocrine resistance, about 25% of these patients had primary endocrine resistance, that is no response to any prior endocrine therapy, whereas secondary, meaning that they responded for some time and then progressed later on, was about 73%. The most recent endocrine therapy in the metastatic setting was in just over a third. Prior aromatase inhibitor in about 70% of these subjects. Metastatic disease site, the simple majority had visceral disease, bone only in about a quarter, other soft tissue sites in the teens. Measurable disease in over 70% of the patients, and as you would expect, over 80% of these patients were postmenopausal, typical of ER-positive disease. This is the primary endpoint. The investigator reported PFS in the intent-to-treat population shown by Kaplan-Meier analysis on the left-hand side of the slide. There was a large difference in median PFS, ranging from 9.3 months in the control arm with fulvestrant and placebo to 16.5 months with abemaciclib plus fulvestrant. And I can't count the number of zeros after the decimal and the p-value because of the small font size that ASCO uses in their slides that they distribute after the meeting. On the right-hand side, you don't need to read the fonts. The point there is the yellow line is unity. That's 1.0. And you can see that all of the various subgroups fall to the left of 1.0 comfortably, with the exception of one, which is the soft tissue predominant metastatic disease. And you can see that the point estimate is still left of 1.0. However, the error bars are very large because that was a very small number of the subjects in this trial. So very solid consistency of the data across all of the subgroups analyzed in the planned subgroup analysis on the forest plot. So really no outliers. Nobody that they could identify that wouldn't stand to benefit from a CDK4/6 inhibitor approach in this data set. Now, interestingly, this agent, as compared to some of the other CDK4 and 6 inhibitors, has more lower GI toxicity in the form of diarrhea. And so this is a little bit more than you would expect to see from either ribociclib or palbociclib, and this will challenge, no doubt, the clinical use of this agent as compared to the other agents in class. The neutropenia rates are perhaps a little bit lower, but not dissimilar. You still have to monitor the counts and adjust dosage, et cetera. So in the end, there are more similarities between the three CDK4/6 inhibitors than differences, but some nuances between one or another in terms of toxicities, and some nuances in terms of screening for eligibility for the various agents. For example, you have to check the QT interval in the case of ribociclib, whereas you don't need to do that, for instance, for palbociclib, et cetera. So all three of these agents, in my opinion, are likely to be available commercially. Two of them already are, of course. And it'll be up to you to decide which one to use and why. But in the meantime, I feel compelled to give balanced discussions with patients of available agents that are approved. And oftentimes they'll have a strong preference one way or the other depending on their circumstances. So this is a summary of the three agents that I just mentioned, two of which are approved, palbociclib and ribociclib. And then abemaciclib has just been given FDA breakthrough designation in the second quarter of this year, and a priority review was granted July 10th, 2017. So the summary of this trial, in my opinion, is that the Monarch 2 trial that I've just shown you with abemaciclib is very much reminiscent to Paloma 3, which was palbo plus fulvestrant, very similar study design as this one, and same as Mona Lisa 3, which was ribo plus fulvestrant. Unfortunately, since Monarch is a 2 and the others are a 3, it won't be simple to remember which ones were the fulvestrant combinations. Sorry about that. Next, there was a lot of discussion about this adjuvant HER2 targeting trial called Affinity, which was the first time that adjuvant pertuzumab was added to trastuzumab and chemo backbone. This is a placebo-controlled trial, HER2 positive early stage breast cancer. And the primary endpoint was invasive disease-free survival. Now you can see here on the left-hand side of this slide that the sample size was 4,805. That is a huge sample size for an adjuvant breast cancer study. And that number was actually increased on the fly during the enrollment of the study because the sponsor recognized that with the planned N of only, I think, around 3,500 initially, that they had far too many node-negative subjects that were enrolled who likely would not contribute any events or very few events. Consequently, they increased the sample size by approximately 1,000, I think. And so you know that the study is going to be in trouble when you have to increase your sample size that much on the fly. But it's a good news for patients that the control arm was expected to do so well just with chemo alone plus trastuzumab. So that's an interesting aside. This is a large multinational, multi-center trial. anthracycline or non-anthracycline-based chemo was allowed, and there was an independent cardiac safety committee as an adjunct to the study. Now, we knew since March of this year, based on a press release, that the study had met its primary endpoint with statistical confidence, and that begged the question back in March, is this statistically significant and exciting, or statistically significant and clinically irrelevant? Those are the two possibilities, with a little bit in between, perhaps. Here's the result. You decide. 4-year invasive disease-free survival hazard ratio is impressive, 0.8, with a p-value just under 0.05. But if you look at the absolute translation of that hazard ratio, it's only about 1.7% at the 4-year mark. One of the questions during the Q&A after this presentation was someone said they couldn't understand why there wasn't a greater absolute benefit. You know, why wasn't it double digit? And the answer was, if you look at 3 years, there was a 93.2% disease-free survival in the control arm. If you have 93.2% in the control, you can't have a double-digit improvement on that. I'm sorry. So I was kind of puzzled by that question because the answer was simple, however disappointing. So this is a big problem. Note that 1/3 of the patients were node negative in this trial and 2/3 were ER positive, and that's why the control arm in DEES has almost, you know, very few events and lower than expected based on historical controls. Now, there are subsets of interest, and I think it's important as a clinician to view this data set from the context of the patient that may be sitting in front of you in your exam rooms. And that is the patients that are N1 have a greater absolute benefit, perhaps around 3%, and the steroid receptor negative patients also had about double the improvement in terms of absolute outcome deltas. So for those patients, it may be, you know, worthwhile to consider this type of an approach. I always think of these things at the extremes. For example, what if you have a 37-year-old with little children in tow who has a 15-centimeter tumor and 17 positive lymph nodes? Are you going to consider adjuvant pertuzumab in that kind of a patient? You bet you are. Of course you are, because the absolute benefits in that context might be quite significant and worthwhile, especially when the outcome may be, you know, curative intent. Now, distant recurrences between the two groups were 4.7% with pertuzumab and about 6% with placebo. There were no differences in the first site of metastasis, including CNS. There was no difference. And the incidence of primary cardiac endpoints was very low, 1% or less in all 3 arms. I'm sorry, in both arms. Now, how does this data set compare to the recently FDA-approved extended adjuvant HER2-targeted therapy with Neratinib, which is a potent, orally bioavailable HER2 kinase inhibitor that also blocks EGF receptor and HER4 kinases. But it is something that has been studied in this extended adjuvant trial. The 2-year DFS has been previously published in Lancet Oncology by Arlene Chan from West Australia. And it showed a statistically significant, but again, small, perhaps about a 2% absolute difference between the two curves, placebo versus Neratinib. So again, hazard was fairly impressive, 0.67 with statistical confidence, but small absolute gains. And of course, this agent, as you may well know, does have GI toxicity as well. In this particular case, about 40% with grade 3 diarrhea, but this trial was done in an era prior to prophylaxis with anti-motility agents, which lowers the grade 3 diarrhea incidence substantially. And the diarrhea usually happens early on in the course of Neratinib and tends to get better over time. So on July 17th, FDA approved this data set as extended adjuvant treatment for HER2-positive breast cancer. Interestingly, if you look at subset analysis of this trial, the benefit in this case seemed to be greater amongst the hormone receptor positive subgroup as compared to the hormone receptor negative control. And it's been argued that this is because of synergy between a combined receptor blockade approach targeting both ER and HER2 as compared to a hormone receptor negative subset, which is an interesting speculation. The FDA indication, as FDA typically will do, is based on the intent to treat analysis and not analysis of subgroups, because subgroups may be underpowered to detect differences, even if they truly exist. So the package insert will not say that this is approved just for hormone receptor positive patients. It's approved across the board, and you'll have to decide in your own mind what to do with the subset analysis pending future data updates. Now, as I mentioned, there's enthusiasm for a combined receptor blockade approach, and this was first demonstrated by Rich Petrus in Dennis Lehman's lab. Look at the date on the lower right-hand side of this slide, 1995. And we had a press release when we published this paper at UCLA in that year. And let me just show you the data. This was on the left, an experiment where we added estradiol to cells that were expressing HER2 and estrogen receptor. We transduced those cells with a reporter plasmid that has an estrogen response element. So estrogen would bind to the estrogen receptor in these cells. The estrogen receptor dimerizes. It's a transcription factor, so it binds to the estrogen response element and turns on estrogen-dependent gene expression like the progesterone receptor, for example. Except in this experiment, we engineered, instead of turning on progesterone receptor and other ERE genes in the human genome, we just had it express a useful reporter called chloramphenylacetyl-transferase, which is convenient and easy and cheap to measure. So you can see on the black bar on the far left, when you add estradiol, there's a burst in estrogen-dependent gene expression in this CAT reporter assay. Tamoxifen, along with estradiol, also acts as a partial agonist in the context of HER2-expressing cells. We confirm that, and it's been confirmed in multiple other laboratories as well in the meantime. Fulvestrant is the blue box. Fulvestrant degrades the estrogen receptor, and consequently that attenuates estrogen-dependent gene expression. Now, the remarkable finding was when we added a HER2 antibody in green. Blocking HER2 affected estrogen-dependent gene expression, and that, I can tell you, at least for me, was a surprise. I didn't expect that perturbation of the HER2 axis would necessarily affect estrogen-dependent gene expression, but in this experiment it certainly did. And the combination of antibody plus fulvestrant in yellow remarkably attenuated estrogen-dependent gene expression. Now, this had biological consequences shown on the right-hand side of the slide. This is an immunostain for G1 or G0 cell cycle arrest using a convenient marker called P21, which is localized to the nucleus, as you can see, under conditions of cell cycle arrest. In the bottom row in the middle, on the right-hand side of the slide, you can see that a HER2 antibody plus fulvestrant dramatically resulted in cell cycle arrest, whereas each individual agent less so, and the positive controls are shown along the top of the panel. So this suggested synergy between HER2 and ER, and this is something that could be tested in clinical models even back in those days, and yet it took many, many years for it to finally be done. We did this experiment that we published in the JCO, Stephen Johnston, I, and others, of a randomized pivotal trial of letrozole lapatinib. It's placebo-controlled. The primary population was the HER2 positive population, shown on the right-hand side, which had an increase in response rate and clinical benefit rate, and a median improvement in PFS from 3 to 8 months with a hazard ratio of 0.7, highly statistically significant. And this won accelerated FDA approval back in January of 2010. Which was 15 years after our laboratory experiment. Fast forward to San Antonio this last December. These investigators also looked at pertuzumab along with trastuzumab plus an anti-estrogen, in this case an aromatase inhibitor, as first-line treatment for HER2 and hormone receptor positive metastatic breast cancer, so quote-unquote triple positive, if you will. And addition of pertuzumab to a trastuzumab endocrine therapy backbone significantly improved PFS with a shift of about, again, 15.8 to 18.9, a modest shift in absolute terms, but a hazard of 0.65 with statistical confidence. Adverse events were as you might expect from addition of pertuzumab. At ASCO this year, another group, in this case, tested the combination of lapatinib and an AI with trastuzumab. So again, a combined HER2 targeting approach with trastuzumab plus lapatinib with an AI backbone. The control groups were the AI plus trastuzumab or the AI plus lapatinib, a 1-to-1-to-1 randomization, 355 patients. Prior treatment with trastuzumab and chemotherapy in the neo or adjuvant or first-line metastatic settings were the eligibility population. About a third had non-visceral disease, half bone mets, half lung mets, 30% liver mets, 30% prior trastuzumab, even in a metastatic setting prior to study entry. These are the top-line results shown graphically. For clarity, I'm showing you Bill Gradisher's PFS Kaplan-Meier analysis comparing the 3-drug combination of lapatinib, trastuzumab, AI versus trastuzumab AI control. On the upper right-hand side, I've typed in the point estimate on PFS for the lapatinib plus AI control, and the 3-drug combination was superior to that control as well, with the p-value shown. So statistically significant improvement in PFS by adding lapatinib to a trastuzumab AI combination, again, underscoring the synergy between a combined receptor blockade targeting both ER and HER2. Obviously, in the lapatinib arm, there are lapatinib-associated toxicities that you're all familiar with. There were no new safety signals for lapatinib in this trial. There were no difference in serious adverse events between the arms, and there was no difference in treatment discontinuation. It was actually less common in the triple drug arm because they had longer responses, arguably. Next, I'll shift your attention very briefly to a paper that we just published that's in press now in Clinical Cancer Research. It's actually published online ahead of print. And these are patients with breast cancer that almost all of whom are estrogen receptor positive. They're all HER2 negative. So these are non-amplified HER2 breast cancers. But they have mutations in the HER2 kinase domain, shown in the upper left-hand side. These mutations we detected in about 5 out of 309 invasive ductal cancers, or about 1.6%. So you have to do a lot of screening. But it's much more common in invasive lobulars, and that difference was highly significant. The mutations were confirmed by circulating tumor DNA. And you can see on the upper right-hand side, we did have responders in the first part of a Simon two-step that was presented at ASCO and also published in the paper, so for an overall clinical benefit rate of about 31%. And one of the Stanford patients is shown below radiographically, showing a partial response. We also noted new mutations occurring while on Neratinib treatment for these mutants, including a T798I, which is analogous to the EGFR gatekeeper resistance mutation that you're familiar with in lung cancer. In the interest of time, I'm going to skip the CNS disease and go straight to the conclusions on the HER2 section, and that is we're enjoying a renaissance of HER2-targeted therapy clinical research in 2017. There's a margetuximab antibody, which is an afucosylated HER2 antibody with greater ADCC activity. That's now in a pivotal phase 3 trial, going toe-to-toe against trastuzumab in the salvage setting. There are bispecific and biparatopic antibody-drug conjugates with faster internalization rates compared to TDM1. There are small molecule pure HER2 kinase inhibitors now that don't block EGF receptor, so they have less diarrhea and less skin rash. One is ONT-380 tucatinib. That's also in a pivotal phase 3 trial that's ongoing right now. Based on work done at Stanford and Ron Levy's lab, we're trying to augment ADCC with CD137 agonist antibodies in combination with trastuzumab and TDM1. And we have combinations with checkpoint inhibitors in our clinic at Stanford undergoing trials also. And finally, CD47 antibodies that can enhance macrophage phagocytosis of tumor targets. A combination with HER2 antibodies has been shown to be very interesting in xenograft assays. And then HER2 targeting along with CDK4/6 inhibition is moving into phase 1b and phase 2 trials. To conclude, OlympiAD is the first phase 3 positive study for BRCA mutant metastatic breast cancer. Despite modest response rate in metastatic disease, checkpoint inhibition is proceeding in the neoadjuvant setting, and I didn't have time to show you the pivotal phase 3 trials that are ongoing in metastatic disease. Randomized phase 3 trials of abemaciclib join the ranks of palbo and ribo. Absolute benefits of adjuvant pertuzumab are minuscule, though the results in high-risk subsets, node positive, ER negative, et cetera, are of clinical interest. Extended adjuvant neratinib with loperamide for 56 days is approved by the FDA just last month. Combined receptor blockade is synergistic, efficacious, well-tolerated, FDA-approved in the ASCO guidelines, and hardly ever used in triple-positive metastatic breast cancer. So for patients who are asymptomatic with low disease burden, this, in my view, would be a consideration. And finally, HER2 kinase domain mutations, while uncommon, respond to neratinib. Second-site resistance is an emerging story analogous to the EGFR story. Thank you very much for your attention, and don't forget the biosimilars are coming in the HER2 space. Thank you.